Karimullah, welcome. Hello, Karimullah. Karimullah, unmute ಮಾಡಿ
sir, now audible, sir.
Now audible కదా. నా వాయిస్ ఓకే క్లియర్ వస్తుందా?
చాలా క్లియర్ గా వస్తుంది మీ వాయిస్.
ఓకే, రైట్. డాక్టర్స్ జాయిన్ అయితే స్టార్ట్ చేసేద్దాం.
yes sir
Gopal sir, good evening.
Yeah, good evening. Am I audible?
Yes, sir, you are audible.
Okay.
Audible, video quality also good, sir.
Okay. So no one has started logging in yet.
Sir, in 2 to 3 minutes, sir.
Okay.
Karthik sir, good evening. Hello. Karthik sir, am I audible?
యా ఆడిబుల్ మీ వీడియో రావట్లేదు
మా వీడియో రావట్లేదు సార్ బట్ యువర్ వీడియో ఇస్ కమింగ్ యువర్ ఆడియో అండ్ వీడియో క్వాలిటీ ఇస్ గుడ్ సార్
మీ వీడియో
సార్ నా వీడియో రావట్లేదు సార్ ఓన్లీ ఆడియో వస్తుంది భూపాల్ సార్ కూడా లాగిన్ అయ్యారు
యా కానీ మధ్యలో ఏంటో ఓన్లీ తిరుగుతున్నట్టు వస్తుంది నాకేంటో నార్మల్ గా
ఇప్పుడు సార్ బాగానే ఉంది
మీటింగ్ లాగా నా స్క్రీన్ మధ్యలో ఇలా తిరుగుతున్నట్టు ఉంది ఇంకా ఏదో లోడ్ అవుతున్నట్టు వస్తుంది
ఓకే अच्छा चेतन जी
यस सर
ये डॉक्टर कार्तिक सर का जो है
हाँ
जिनका विकी कैरी लिखा हुआ है ना
ओके
तो कार्तिक सर का कुछ लोडिंग जैसे दिख रहा है करते उनका कुछ इश्यूज है क्या टेक्निकल इश्यूज
आई एम नॉट एबल टू इवन लॉग आउट
डाउन ये है ना इसकी वजह से वो लोड हो रहा है एक्चुअली
लोड हो रहा है
हाँ रीनेम चेंज करना था क्या
ठीक है लेकिन क्या है ना सर का कुछ मतलब लॉग आउट करने का भी ऑप्शन नहीं दिख रहा है करके बोल रहे थे
एक सेकंड
कैन यू जस्ट एंड मी आई विल जॉइन अगेन
हाँ चेतन जी
सर जस्ट रीजॉइन अगेन
हाँ सर को डिस्कनेक्ट पे कर दीजिए पहले उसको फिर रीजॉइन करेंगे सर
ओके
Yeah. Hello.
Karthik sir, now is it okay?
Yeah.
Sitaram sir, welcome. Good evening. Sitaram sir, your audio is not coming. Please unmute.
హలో కార్తిక్ సార్.
సీతారాం, ఏం సంగతులు?
సార్ భూపాల్ సార్ బాగున్నారా?
బాగున్నా. ఏం సంగతులు?
ఖమ్మం షిఫ్ట్ అయ్యాను సార్.
ఖమ్మమా? ఓకే.
ఏప్రిల్లో షిఫ్ట్ అయ్యాను.
ఓకే. ఖమ్మం ఏంటి క్యాట్ ల్యాబ్ ఉందా లేకపోతే ఏంటి?
అంటే తీసుకున్నాను సార్, అది ఇన్స్టాల్ అవ్వలేదు. ల్యాబ్ వచ్చేసింది. అంటే సన్షైన్ లో ఇది ఆర్టిస్ట్ జీ ల్యాబ్ ఉంది, వాళ్ళు తీసేస్తున్నారు వాళ్ళు పైన. ఆ ల్యాబ్ నేను తీసుకున్నాను.
ఓకే. అంటే నువ్వు ఓన్ సెటప్ స్టార్ట్ చేసుకున్నావా?
అంటే ఇక్కడ మల్టీ స్పెషాలిటీ హాస్పిటల్లో
కార్డియాలజీ వింగ్ నువ్వు తీసుకున్నావు. ఓకే.
అవునవును.
అదేలే.
సీతారాం సార్, గుడ్ ఈవినింగ్ సార్.
అరే ఏంట్రా గడ్డం పెంచడం ఏంట్రా? ఇంకా భూపాల్ సార్ మనోడు శివకృష్ణ ఇలా ఇదొకటి రోటా చేశాడు.
అదే పెట్టాడుగా వీడియో, ఎందులో ఫేస్బుక్ లో పెట్టాడుగా.
ఆర్సీ ఫస్ట్ ఆర్సీ చేశాడు, బాగానే చేశాడు, సూపర్ వచ్చింది రిజల్ట్.
అవునవును.
మీరు ఇది అయోటిక్ గ్రాఫ్ట్ స్టెంట్ చేశారా?
టెవార్ 2 చేశాం కదా. టెవార్లు
ఎక్కడ అంటే డిసెండింగ్ ఆర్చా?
ఆర్చ్ మనం చేయాలి. ఆర్చ్ కాంప్లెక్స్ కదా, డీ బ్రాంచింగ్ అవన్నీ చేయాలి. మనం డిసెండింగ్ అనే చేసాం 2.
అవునా? నేను ఒకసారి
ఆర్చ్ చాలా హై రిస్క్ అబ్బా, అంత ఈజీగా అటెంప్ట్ చేయలేదు. డిసెండింగ్ అయితే ల్యాండింగ్ జోన్ బాగుంటే షార్ట్ సెగ్మెంట్ అయితే ఈజీగా చేసేయచ్చు.
అంటే ప్రోక్టర్ వస్తారు కదా సార్, అంటే మీరే చేస్తారా?
ప్రోక్టర్ వస్తారు, మనతోనే చేయిస్తాడు.
ఓకే. అదే నా కేసుకి అది ప్రాక్టర్ వచ్చాడులే, కానీ ఆ కేసు పోయింది. ముసలావిడ ఆర్చ్ కాకుంటే అదే మీ దగ్గర వచ్చిందని చెప్పింటాడు ప్రాక్టర్.
చేశారా?
చేసాంలే, కానీ డెత్ అయింది సార్. అది స్టెంట్ కదిలిపోయింది. తర్వాత అది మనం చేసిన
రిస్క్ అబ్బా. ఎప్పుడైనా ఆర్చ్ చాలా హై రిస్క్, ఎందుకంటే నీకు ఇవన్నీ డీ బ్రాంచ్ చేయాలి కదా, కెరోటిడ్ అన్ని. అంటే ఇండికేషన్ ఏంటి అంటే ఒట్టి ఎన్యూరిజమా?
డక్టల్ ఎన్యూరిజం సార్. మనము పీడిఏ వచ్చే దగ్గర పెద్ద ఎన్యూరిజం. ఒకసారి నేను పెట్టినట్టున్నా మన గ్రూప్ లో, మీరు చూసారో?
నేను చూడలే.
పెద్ద ఎన్యూరిజం, చాలా పెద్ద ఎన్యూరిజం, చిన్న నెక్ అన్నట్టు. అది వాళ్ళు సిటీ వాళ్ళు ఏమన్నా చేస్తారా అంటే అది దాదాపు 75 years ముసలా.
మీరు ఎలా చేశారా అంటే ఏంటి, డీ బ్రాంచింగ్ చేయించారా ముందు సర్జరీ?
డీ బ్రాంచింగ్ కాదు, అది ఫెనిస్ట్రేషన్
చేయించారా? ఓకే.
అక్కడే టేబుల్ మీదనే ఫెనిస్ట్రేషన్ చేశాడు.
ఆన్ టేబుల్ ఫెనిస్ట్రేషన్ చేసి
అది ఏది మన బొవైన్ ఆర్చ్.
రిస్క్లే. ఆర్చ్ టెవార్ చాలా హై రిస్క్.
ఇంకా తగ్గినాయి సార్ కేసులు ఇప్పుడు?
తగ్గుతున్నాయి ఇప్పుడిప్పుడే. కొంచెం మా దగ్గర 100 కేసులు ఉండేవి, ఇప్పుడు 60.
అంటే ఇప్పుడు మీరు హాస్పిటల్ ఇన్వెస్టరా సార్, లేకపోతే ఓన్లీ క్యాత్ ల్యాబ్ లాగా?
మేము హాస్పిటల్ ఇన్వెస్టరే.
ఓకే. ఆంధ్ర హాస్పిటల్ కదా సార్? కాదు క్యాపిటల్. అదే ఖమ్మానికి బాగానే వస్తున్నారు విజయవాడ చుట్టుపక్కల వాళ్ళు.
విజయవాడ నుంచి ఖమ్మం వస్తున్నారా?
విజయవాడ చుట్టుపక్కల వాళ్ళు అంటే ఆంధ్ర ఉన్నారు కదా సార్ ఇప్పుడు.
బానే ఖమ్మం, సత్తుపల్లి
వాళ్ళు వస్తారు, బాగానే వస్తారు.
సత్తుపల్లి వాళ్ళు ఇటు విజయవాడ వస్తారు బానే.
అక్కడ హైదరాబాద్ లో జాబులు చేసి కేసులు చేసి అలసిపోవడం తప్ప ఏం లేదు సార్. మామూలుగా వాడుకోవడం లేదు. శాలరీ బేసిస్ గా ఉండేది కదా.
అంతే.
రేడియేషన్ లో ఈ అమ్మ చచ్చిపోవడం తప్ప ఏం ఉండదు. కేసులు రోజు చేసేది కొన్ని రోజుల తర్వాత పిచ్చిలేసింది, వదిలేరా బాబు అని సెట్ షిఫ్ట్ అయ్యా. కార్తీక్
మీటింగ్ లో ఎవరు జాయిన్ అయ్యారో చూడండి ఒకసారి.
నో బాబు నువ్వా?
శివ సార్.
ఏం శివకృష్ణ ఉన్నాడా?
ఆ,
నేను మ్యూట్ లో ఉన్నాడు.
సార్
శివ
మ్యూట్
సార్
లో ఉన్నారు సార్.
సార్ మ్యూట్ తీయండి శివ సార్.
సార్ మ్యూట్ లో ఉన్నారు సార్.
హాయ్ హాయ్
ఏం బాసు?
బాసు బాగున్నావా? చాలా
బాగున్నా. ఏం సంగతులు? ఏం
నీ
ముసలాడు
గురించే
అయిపోయావు?
మాట్లాడుకుంటున్నాం.
మొత్తం తెల్ల జుట్టు, తెల్ల గడ్డం,
ఏజింగ్
స్టైలా? సాల్ట్ అండ్ పెప్పరా?
సాల్ట్ అండ్ పెప్పర్.
కార్తిక్ సార్ గుడ్ ఈవినింగ్.
యా గుడ్ ఈవినింగ్.
మా అసలు రొటాప్లేషన్ మంచి సీనియర్ మోస్ట్ ఇంటర్వెన్షనల్ కార్డియాలజిస్ట్ అయిపోయావుగా.
అమరాని ఒక షోల్డర్ మీద లేపుతున్నాడు సార్.
అవునా?
అందుకనే కొంచెం తెల్ల జుట్టు మెయింటైన్ చేస్తున్నా. గడ్డం కూడా తెల్ల ఏదైనా ఆయన అసలు ఒక 6 నెలల్లో తెల్లగైపోయింది.
ఆ రేంజ్ లో ఎఫర్ట్ పెడుతున్నావు క్యాత్ ల్యాబ్ లో. మరి రేడియేషన్ కి
ఏం సంగతి? నువ్వు ఎట్లున్నావు? అసలు సీత అట్లే స్మార్ట్ గా ఉన్నాడు.
చాలండి.
సీతారామా?
వాడే మరి
సీతారాం పవర్ స్టార్ కదా.
సినిమా పోయినాడో లేదో మరి? రీసెంట్ పోయి చూసినావా?
లేదు సార్, ఇప్పుడు నేను వాడి ఫ్యాన్ కాదు ఇంకా.
ఏ క్యాత్ పెట్టేసరికి మర్చిపోయినాయింది. అరే ఒక్కసారి హెయిర్ స్టైల్ చూడు, అంతా అదే కదా.
అసలు మామూలుగా కాదు.
మీరు మాట్లాడితే అందరు వినాలా?
అంతేగా.
మీరు డిబేట్ చేస్తే అందరు వినాలా అంటున్నా.
నీ ఇష్టం బాసు, ఏంటి లేకపోతే లేదు. ఏముంది?
మీరే కాంట్రాడిక్ట్ చేయాలి రాజా.
నేనేం చేయను.
నీ ముందు నీతో డిబేట్ చేసే సాహసం మేము చేయగలమా చెప్పు?
వాసు నువ్వు ఆగు వాసు. సరే మీరు కానివ్వండి, నేను చదువుకోవాలి కొంచెంసేపు. నేను ప్రాముగ్రల్ చేయాలా? ఏం చేయాలి? వాడు చిన్న పట్టుకొచ్చినాడు.
అమ్మాయా?
వాడు కొడుకు.
అబ్బాయా?
అబ్బాయి సార్.
ఓకే ఓకే, బాగుంది. నైస్, క్యూట్.
శివకృష్ణ సార్
ఎంబోలైజేషన్
రేపు ఉంది ప్లాన్.
సాయిల్స్ తెప్పిస్తున్నా, రేపు చేయాలా.
అవునా?
మళ్ళీ తీరాడ పోయినాక మళ్ళీ ఎత్తుక్కోకుండా కొంచెం ముందు ప్రిపేర్ కావాలి కదా, ఏం చేయాలా, ఎట్లా ప్లాన్ చేయాలని.
ఎందుకు ప్లాన్ చేసేది ఏముంది? ఎంత ఉంది సైజు?
అంటే ఒక క్యావిటీలోకి అన్యూరిజం ఉంది. అన్యూరిజం నెక్ వచ్చి 3 millimeters ఉంది.
ఫీడింగ్ ఆర్టరీ ఏంటో మీకు ఇందులో పల్మనరీ
కొల్లెటరల్స్ ఉంటాయి కదా, ఒకటి బ్లాక్ చేస్తే ఇంకోటి ఓపెన్ అవుతా ఉంటది కదా.
అదే అందుకే మెయిన్ ప్రాబ్లం అదే.
సిటీ చేయించావా?
సిటీ చేపించిన భూపాల్. సిటీ చేపించిన. సిటీలో రేడియాలజిస్ట్ ఏమో ఒకటే చూపిస్తున్నాడు. సార్ ఇది ఒకటే చేయండి అంటున్నాడు.
అంటే ఫీడింగ్
రెండు చెక్ చేసి చూసి సెలెక్ట్ కమరెన్స్
తెలుసు.
అదే ఫీడింగ్ ఆర్టరీ ఒకటే ఉందని చెప్తున్నారు అంటున్నా.
ఎక్కడి నుంచి అది? అయోటానా
పల్మనరీ ఆర్టరీ నుంచి వస్తుంది.
హలో,
పల్మనరీ ఆర్టరీయా?
సరే
వీనస్ పంక్చర్ తీసుకుని ఎంటర్ అవుతారా?
ఆర్టరీ కూడా చేయాలిగా. బ్రాంకియల్ ఆర్టరీ కూడా ఇంజెక్ట్ చేసి చూడాలి కదా. చూడకుండా రాలేం కదా బయటికి. ఒకవేళ బ్రాంకిలైటిస్ థిన్ గా ఉన్నాయంటే ఎంబులైజ్ చేయకుండా వచ్చేస్తాము, లేదంటే దాన్ని కూడా చేసుకుని రావాలా.
కొన్నిసార్లు ఈ థైరో సర్వైకల్ ట్రంక్ నుంచి కూడా కొల్లెటరల్స్ ఉంటాయి.
అవును, ఆర్చ్ ఆఫ్ ది అయోటా నుంచి,
బ్లాక్ అవ్వగానే అవి ఓపెన్ అవుతాయి.
అందుకే బాగా లాంగ్ ప్రొసీజర్ చూడాలి మరి రేపు. సరే మీరు కానీ మాట్లాడండి, వింటా ఉంటాను.
సరేలేండి.
బై.
సో కార్తిక్ నాయక్ సార్. హలో కార్తిక్ నాయక్ సార్. Dr. Karthik Naidu?
Yeah, speaking.
Yeah. Sir, shall we go ahead? Shall we start? Yeah, sir.
Can we start the session now?
Everything is settled, sir. Now we'll start the session. Omkarji.
Yeah, we can go live in around 30
We
seconds.
can go live.
Just a minute. Chetan, please go live.
Actually, there is a signal issue, so my video may not work properly.
Not a problem, sir.
Okay.
Not a problem, sir.
Am I audible?
Yes, sir,
sir.
you're audible.
How is my audio?
Audio is good, sir. What we'll do now, sir? So I will introduce moderator as well as panelists. Then we can go into the subject, sir.
Sure. Yeah.
Oh, okay, sir.
We can start, Ranjit, sir.
Yeah.
Sir, we
Good
are
evening,
live
all.
now.
Good evening, all. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I welcome our eminent moderator, panelists, and all the doctors who have joined us for today's antithrombotic debate. At Alchem, it has always been our endeavor to partner with healthcare professionals, and we continue to do so during this pandemic time also. To help us navigate through this meeting, we have with us renowned cardiologist Dr. K.C. Karthik Naidu, who will moderate today's debate. Dr. Karthik Naidu, well-known face, no need of introduction, but still, Dr. K.C. Karthik Naidu has done his MBBS from prestigious Bangalore Medical College and Research Institute in 2006, done his MD in internal medicine from Sri Devraj URS Medical College, DM in cardiology from MS Ramaya Medical College, also pursued an MBA from Kent Business Schools in the United Kingdom. Currently, he is working as an assistant professor in cardiology at Pinnamanelli Siddhartha Medical College, Vijayawada. At the same time, we also take this opportunity to welcome our eminent panelists today's program, Dr. V.S.R. Bhopal, Dr. V. Sitaram, Dr. T. Viswanath Karthik, and Dr. R. Ganesan. Dr. V.S.R. Bhopal has done his MBBS from Siddharth Medical College, MD General Medicine from NRI Medical College, Vijayawada, DM in cardiology from prestigious Nizam Institute of Medical Science, Hyderabad. Currently, he is working as an international cardiologist and head of the cardiology department, Capital Hospitals, Vijayawada. Dr. V. Sitaram completed his MBBS from NTR University of Health Science in Andhra Pradesh, 2011. After he completed his MD in General Medicine from Dr. NTR University of Health Sciences, Andhra Hospital, 2014, he also completed his DM cardiology from NIMS Hospital, Hyderabad in 2018. Currently, he is working as a cardiologist in C-Star Sankalpa Hospital, Khammam. And I would like to welcome Dr. T. Viswanath Karthik. Has done his MBBS from Rangaraya Medical College, done his MD from General Medicine degree from Osmania Medical College, DM Cardiology from Sri Chaitanya Tirunal Institute of Medical Sciences and Technology. Also, he has done his FESC Europe. Currently working as a consultant cardiologist at ANU Institute of Neuro and Cardiac Sciences, Vijayawada. And Dr. R. Ganesh will be joining soon because of some technicality issue. He could not join. He'll be joining soon. As you all know, Dr. R. Ganesh is a MDDM cardiologist currently working as assistant professor in cardiology, Mamta Hospitals, Khammam. With this introduction, I would like to request Dr. K.C. Karthik Naidu to initiate the program proceedings. Over to you, Karthik sir.
Yeah. Thank you very much.
Thank you, sir.
Good evening, one and all. First of all, I would like to thank the CIPLA team for organizing such an interesting meet. And to Alchem, I'm very sorry, Alchem, for organizing such an interesting meet on two important clinical topics. One related to the acute coronary events and the other one related to atrial fibrillation. So to start the session, I would just introduce a case scenario which we come across in everyday practice. And based on this case scenario, we will have the real world discussion and data analysis on how the drug choices are being made by physicians, which would help the other cardiologists to make the choices. So the first case here is of a 72-year-old male who came into the emergency department complaining of sudden onset chest pain of 1 hour duration. Typically, the pain was cardiac in origin. The patient was a smoker, non-diabetic, with a history of hypertension. His EKG showed an extensive inferior wall MI with elevated biomarkers and BP of 130/70 and heart rate of 70 beats per minute. The patient was ready for intervention. Next slide, please. So this is the ECG of the patient, which shows an extensive inferior wall MI. Next slide. So the treatment plan was, of course, to do a primary for this patient. The patient was taken for primary and the PCI to proximal RCA was done. And then subsequently a PCI to circumflex artery also was done, which was a staged procedure. And the patient now has got 2 drug-eluting stents. Next slide, please. So now comes the big question, which dual antiplatelets to choose, and what is the duration of continuation of dual antiplatelets therapy for this patient who has 2 drug-eluting stents implanted. So that usually in a primary, we have seen that many a times we use Aspirin as the first antiplatelet and the second antiplatelet being clopidogrel or ticagrelor. Of course, Prasgrel also has gained widespread acceptance, especially among the young patients. So a loading dose is always given, followed by a maintenance dose. So now that we have seen that we have 3 combinations of dual antiplatelet therapy available in the current scenario, which includes aspirin, of course, as default as the first antiplatelet, followed by either a clopidogrel or Prasgrel or ticagrelor. So I would like to start the discussion on this topic, on the real world scenario, on which antiplatelet to be used and in what circumstances does the clinician drives the choice of his antiplatelets for a particular patient. So to open the talk, I would like to invite Dr. Bhupal, Dr. Sitaram Garu, and Dr. Ganeshan and Dr. Ranjit. So
it's from Alchem, sir. Dr. Vishwanath Karthik is there from Anu Hospital.
Yeah. Sorry,
Yeah.
Dr. Vishwanath Karthik Garu. Yeah. So Dr. Vishwanath Karthik Garu, I think Dr. Ganesh has not joined yet.
I think
Hello.
he has joined. He is there as an attendee.
Acha. Okay. So I would like to open the session for discussion with Dr. Bhupal Garu, Dr. Sitaram, Dr. Karthik Garu, and Ganeshan. So the first question that I'd like to ask is, in a patient like this, given the scenario that he is non-diabetic, middle-aged smoker, and hypertensive, presenting with an inferior wall MI. So starting with Dr. Bhupal Garu, what is the first antiplatelet that you would consider? Ignoring the fact that aspirin is by default the first antiplatelet choice. So as a
Default is aspirin, as we all know.
Yeah.
Aspirin is the default antiplatelet of choice, which you should use irrespective of what you are using along with it. So aspirin, then the other antiplatelet you need to consider. You have 3 choices: clopidogrel, Prasgrel, and ticagrelor. Considering his age, I mean, going by guidelines, whenever there is a choice, always prefer Prasgrel or ticagrelor or clopidogrel. So if there are no financial constraints or there are no other, high bleeding, if there is no any, high bleeding risk category, if the patient doesn't fall into any high risk bleeding category, definitely you should consider either Prasgrel or ticagrelor in comparison to clopidogrel. And again, in this patient, as he is 72 years old, so he is slightly at a higher risk of bleeding. So as we know, Prasgrel is contraindicated in patients above 75 years of age and patients less than 60 kgs and female patients. Patients with history of stroke or TIA. So definitely in this patient, though he's not above 75, he is nearing 75. His age is 72. So definitely I would prefer ticagrelor to Prasgrel. So my choice of loading dose would be aspirin along with ticagrelor 180 mg.
Okay.
In this patient.
So now I would like to move on the debate to Dr. Karthik Garu to see what are your choices of antiplatelets for this patient. in a scenario like this?
Definitely, as Bhopal sir told, first I'll consider as 300 milligrams of aspirin, and the second antiplatelet will be ticagrelor, because all the recent studies and previously we used to use clopidogrel, but definitely ticagrelor is doing well than the clopidogrel. And recently, I have seen even some patients who are using ticagrelor after stenting, and because of some financial issues, they stopped using ticagrelor. And when we switched them to clopidogrel, they had new onset LV dysfunction, some developed stent thrombosis. So very rarely, but still there is a chance with other antiplatelet. Ticagrelor, as of now, we are finding it very safe. Because, and also with clopidogrel, some patients because of this hepatic enzyme issues and different
resistance,
clopidogrel resistance and all, some patients are not responding to the clopidogrel. So by default, we are using aspirin with ticagrelor only. And Prasgrel rare, because one thing is usage by the other cardiologist, and the other thing is the Prasgrel has a risk of in elderly patients has a risk of stroke, and we cannot use Prasgrel in those patients who had a previous ischemic infarct or any TIA history. We cannot use Prasgrel. So we are using aspirin 300 with ticagrelor 180 as loading dose. And recently, one patient, one COVID patient, I remember, one COVID patient, the patient is on stenting done 5 months back, because he has to be started on this antithrombotics, this apixaban and all, because of high bleeding risk. We gave loading dose of 600 milligrams of clopidogrel to him, and wanted to change him to clopidogrel with low molecular weight heparin, but still he, after changing to clopidogrel, there is a new onset mild LV dysfunction in that patient. So immediately again switched back to ticagrelor and kept him on low molecular weight heparin. So I don't think post PCI, if the patient is given a loading dose of ticagrelor and patient is continuing ticagrelor, means whatever it is, till at least a period of 1 year, we should not stop ticagrelor at any cost. That is what I feel.
Thank you, sir. So now coming to the second important question. Now that we have seen that by default, after aspirin, the antiplatelet most commonly chosen is becoming ticagrelor, and ticagrelor is gaining its importance. So the second important question that comes to the discussion is, how long would you like to continue the antiplatelet regimen, that is the dual antiplatelet regimen, in this kind of patients, that is the elderly patient who is a non-diabetic resident and smoker, with the pre-circulating stents implanted in his coronaries? So for this question, I will invite Do we have Dr. Ganesh, sir?
No, sir. Ganesh is not yet joined.
I think
I'm joined. I'm joined.
Sorry,
Yes.
sorry. Yeah, Ganesh, sir.
Can I start?
Okay, sir.
Make comment? Hello.
Sure, sir. Sure, sir.
Yeah.
Yes, sir.
Depends upon patient's clinical features and bleeding risk we have to calculate before giving any loading dose. The patient's clinical features means age one of the important factors, and procedure is very simple lesion, the very less thrombotic load, single short stent, then the chance of stent thrombosis is less. You can go with clopidogrel. Everything decides upon our clinical feature as well as the patient bleeding risk factor. If patient's age is high and any other bleeding risk is anemic or mildly elevated urea creatinine, then the bleeding risk will be there. So we have to see the precise DAP score. If DAP score is more than 25, then the chance of thrombosis is, we have to calculate the precise DAP score. If cutoff is 25. If based on that we can choose. And one more comment is no React 5 trial shows no much difference with Prasgrel and Ticagrel as in causing the stent thrombosis and bleeding risk also. Almost both are same only. The only difference is no Ticagrel is a more rapid onset of action, so you can use loading dose. Prasgrel will have slow onset of action, but before knowing the coronary anatomy, you cannot give Prasgrel. That is one disadvantage is there, and it's slow onset of action. That one is important disadvantage for Prasgrel. But bleeding, if you see the bleeding risk, bleeding complications, major bleeding complications are almost similar that shows in a React 5 trial. So I will use depends upon how the lesion is simple or how many stents we are using, how long stents we are using, how stent thrombosis, how much thrombotic burden is there. We will see all these features and as well as the patient bleeding is. Based on that, we can take decision instead of just neglecting the Prasgrel. I think it's just myth. Everybody thought that it's more potent and it will cause more bleeding manifestations, bleeding complications. So we are using regularly more of Prasgrel rather than Ticagrel, and we rarely see any bleeding complications. Hello.
Thank you, sir. That was a very wonderful explanation on choice of antiplatelets, because you have touched some of the key clinical points, which I would discuss towards the end of this session. Now, coming to the other important question, Dr. Sita Ramgal, in your practice,
Yes.
what is the percentage of patients you prescribe, you put them on ticagrelor, and what is the percentage of patients you put them on clopidogrel? And over a period of follow-up of 1 year, what is the incidence of major adverse cardiovascular events that you have noted among those patients?
Most of the time we do interventions for acute coronary syndrome, sir. So hardly we use clopidogrel as a second antiplatelet. Most of the time we give the ticagrelor only. And ticagrelor, most of the time, at least we use for 3 months. If the patient finances problem is there or any other problem, at least use ticagrelor as a second drug for 3 months. And after 3 months, I switch over to the clopidogrel if the finances constraint is there. Otherwise, only the ticagrelor. And we have done one study at the Nizams, that is the same clopidogrel resistance by using the genetic testing. In that case, we have compared both ticagrelor versus clopidogrel, and there we have clearly seen that especially the acute coronary syndrome cases or any complex interventions, and those cases when we started the clopidogrel, and such patients they back with the stent thrombosis, or the most of the time they came with the stent thrombosis, which we haven't seen in the ticagrelor, and we have prematurely terminated the study because of the excessive or the more number of stent thrombosis with the clopidogrel drug. So in my use, most of the time I use the ticagrelor than clopidogrel. After 1 year, I switch over to the clopidogrel. Usually, if any finances constant, then after 3 months I switch over to the clopidogrel.
Okay. So now the second question: what are your points number 1, 2, and 3 driving you towards choice of ticagrelor, and what are your points number 1, 2, and 3 driving towards your choice for clopidogrel in general? Let's just come out of this topic and leave the elderly patients and then come in general.
Okay, for ticagrelor driving is that is a short answer.
I'm sorry. Yeah, I'm sorry, sir. So the other thing that I would like to include in this question is, are your choices depending upon the patient-specific factors or the factors related to your coronary angiogram, that is the lesion-specific factors, or are your choices driven by some other external factors?
Most of the time, I'll depends on the patient's presentation, sir. Is it acute presentation or the stable anginas? The second point comes to the complexity of the lesion, and that is either when we are doing bifurcations or the LMCA lesions or any proximal or osteal lesion, then definitely I consider as a high risk for a thrombotic burden. And then I choose most of the time for the ticagrelor. The only problem with ticagrelor is it has short half-life. The patients skip one dose also, then in the patient, the chances of the stent thrombosis will be very high. Their Prasgrel will be scoring over the ticagrelor. Other than that, clopidogrel, most of the time we haven't used after the study which we have done in the Nizams. So any complex lesion or any LMC or osteal lesion, acute coronary syndrome, we don't start the clopidogrel unless otherwise there is any significant bleeding risk. Then only we choose for the clopidogrel. And Prasgrel, yes, we use for at least ROGST cases. Once we have realized that the patient not require for any surgical correction, then only after knowing the coronary anatomy, we start Prasgrel, and we didn't have any problem with Prasgrel, especially the bleeding risk. And we selectively use Prasgrel when it compared to the ticagrelor.
Okay, thank you, sir. Now, a question to Dr. Bhupal, sir.
Yes.
Sir, now
Yes, sir.
in your practice, what is the incidence of minor and major bleedings that you have come across amongst the patients on ticagrelor and on clopidogrel? Did you find any major difference in the bleeding incidence?
Frankly speaking, I did not come across any major bleeding with ticagrelor as of now, luckily. So, though, I mean, reports have shown that ticagrelor has slightly increased risk of non-CABG related bleeding compared to clopidogrel. In my practice, I did not come across any, patient having a CVA, due to ticagrelor, luckily. So, or else, any GI bleed or anything. So, as of now, I haven't come across any patient with major bleeding with ticagrelor.
Okay.
So I've been using ticagrelor, quite frequently, compared to clopidogrel, and so I don't think bleeding is an issue with ticagrelor, maybe in Indian population. As part of, my practice is concerned. Probably I don't know about others.
Okay. Dr. Ganeshan, sir. Are you there, sir?
Yeah.
Sir, I have a question for you now. Do you have any real-world experience of ticagrelor in the octogenarians?
No, most of the patients who I would say very organized or high thrombus, so we rarely use ticagrelor. Only for us, we use either clopidogrel or Prasgrel. We have to consider the patient's economical. So I will use Prasgrel or Prasgrel. These two only.
Okay. Okay. That was an interesting discussion on the antiplatelets choice. So to sum up this, yeah, definitely the choice of making a choice of antiplatelet in a day-to-day clinical practice, especially in a cath lab when we are dealing with an acute coronary syndrome, is not an easy job. It involves considering several factors, which could be patient-related, the financial-related, and sometimes even the lesion-related. So many a times, especially when the patients require multiple stents or long stents, there is always a fear and risk that the patients might end up with restenosis or thrombosis, stent thrombosis. So these risks, especially when they happen within the first year of life, can be very devastating to the patient. And so these sometimes even drive the physician towards choosing newer antiplatelets, which have better profile in keeping the stents patent for as long as possible. So although aspirin with clopidogrel combination has stood the test of time for the last 3 decades since the intervention started, But there were certain caveats with usage of clopidogrel, and then this led to newer antiplatelets like Prasgrel and ticagrelor. So, the issue was, how was the real world strategy now at current scenario, and which antiplatelet is now becoming fast popular in terms of safety and efficacy? So in this regard, there was one trial which was conducted in Italy. It's called as, rather than trial, it was a registry. It's called as a START registry, START antiplatelet registry. And in that registry, they found, they collected the real world data from about 7 or 11 participating hospitals across Italy. And they analyzed the data to see which antiplatelet in the real world was most commonly prescribed, what were the side effects, and what were the incidence of major adverse cardiovascular events. In fact, it was quite interesting to note that in that study trial, the incidence of stent thrombosis or stent restenosis rate was very, very less. So the credit goes to the lower incidence, the credit goes to the advancements in the stent technology. So as such, with the usage of the drug-eluting stent, the risk of revascularization after stent implantation in the first year has come down a lot. And with the support of the better dual antiplatelet regimens, the incidence was further reduced. And the most important finding they observed was the most commonly prescribed antiplatelet, apart from aspirin, in that trial was ticagrelor. So nearly 45 to 50% of the patients in that registry were put on ticagrelor at the time of discharge. And 1/3 to 1/2 of the patients had received more than one stent. And at the follow-up of 1 year, which involved, so at the end of follow-up, which involved about 1,000 to 1,500 patients, they found that the incidence of restenosis and major adverse cardiovascular events were significantly less. And bleeding issue also was not a major problem with the usage of either of any of these three antiplatelets. But when they did a subgroup analysis, they found that the incidence of bleeding was little higher with Prasgrel, of course, in the elderly patients, but not in the youngsters. So when it came to youngsters, as Dr. Ganeshan sir was pointing out, in an Indian scenario, if we contemplate the data, so in an Indian scenario where the financials drive the major issue of continuation of treatment for the patients, expensive drugs may be very difficult to continue for a long term. And just as brought about by Dr. Sitaram in that case, that antiplatelets can be given for the initial few months, if possible, whenever there is a choice, and then we can switch over. Although there were some reservations with switch over to dual antiplatelets with the incidence of revascularization. But if we contemplate the data to the real world scenario, in a younger patient, for a simple lesion, which involves a single stent or short stent implantation, so as rightly told by Dr. Ganeshan sir, I don't think the choice of antiplatelet would be an issue, provided the patient does not have other associated medical conditions like familial dyslipidemias or diabetes mellitus with poor control, or diet and lifestyle modifications not attained even after the index event. So if these are the conditions which can consider that, which can put the patient at risk for future adverse major cardiovascular events, then I think the choice should be more stricter in choice of antiplatelets. But if the patient has no comorbidities with just a single short stent or two or three short stents implanted with low risk of future major adverse cardiovascular events, then choice of antiplatelet can be subjected to individual physicians. And of course, the choice again, since ticagrelor is becoming more and more popular for multi-vessel PCIs, can be considered, if not for long, at least for a short duration before it can be switched over. So this is one point that was to be highlighted. However, when it comes to the elderly patients, yes, there are always reservations with regard to the bleeding risks. So, but then there have been trials, especially with ticagrelor. There was a recent trial, and even in the in the recent trial, they have analyzed the safety profile of ticagrelor even in the octogenarians, and they have found that ticagrelor has been very safe in usage. even in the elderly, with the bleeding risk comparable to that of clopidogrel. However, with lesser incidence of major adverse cardiovascular events and target vessel revascularization. So yeah, in the plateau subgroup analysis of the plateau trial, exactly, yeah. So antiplatelets, yes. In case if the patient is at a high risk category for developing stent thrombosis or stent restenosis in the immediate future, then I think considering newer antiplatelets would be reasonable. But however, if such a risk is low for the patient, then a choice of antiplatelets can be subjected to discretion of individual physicians. So that's what I feel based on the data that was available so far, and even based on the real world registry that was happening in different part of the world, although not in India. So with this, I would like to hear for any other additional comments from the eminent panelists, if they want to add anything apart from this.
Previously, it was told in a young patient, you can use clopidogrel. So, Bhopal sir, like, what do you say regarding that?
Usage of clopidogrel in young patients. I prefer using Prasgrel in young patients compared to, ticagrelor, for the simple reason it is easy to use. Compliance is better, single daily dose. So I prefer Prasgrel to clopidogrel or ticagrelor in younger patients. Clopidogrel, given a choice, I prefer Prasgrel and ticagrelor or clopidogrel. Almost, patients who undergo, simple angioplasties in, Arogyasri scheme, and who can't afford paying for their antiplatelets, I think I use clopidogrel. Other than that, there is no indication for clopidogrel as far as my practice is concerned right now. I only use Prasgrel or ticagrelor if the patient is affordable, and if the patient is young, I prefer Prasgrel. If the patient is elderly, I prefer ticagrelor.
And there are no combinations of Aspirin and Prasgrel, na? Even if once daily dosing.
There is one combination, I think. I have seen some prescriptions.
Clopidogrel and Aspirin, we have hundreds of combinations.
Yes.
Even if once daily, I think Prasgrel and Aspirin, I think there are no combinations of.
I have seen a few prescriptions, but I don't know if it is freely available or not.
Okay. Yeah, it is available, but 2 pills you need to take.
Yes,
the same Aspirin and
like same
ticagrelor,
like a combi pack.
Exactly. Pill burden won't be different, but
there is no combination drug.
Yeah,
single tablet. I don't think it is there.
And Prasgrel, what other side effects you have seen, sir, other than?
Prasgrel, only side effect is if we are choosy. If we use it only in young patients, I don't think there will be a big problem. Though increased bleeding risk is being stressed upon in the literature. If you are, if you choose Prasgrel, choose the patient wisely. Younger patients and with high thrombotic burden, I don't think bleeding with Prasgrel is an issue. And moreover, in the recent trial, as Dr. Ganesh has rightly mentioned, in ISAR React 5 trial, there is no difference in major bleeding between ticagrelor and Prasgrel when compared. So, I think bleeding has been overstressed for Prasgrel, and definitely it is contraindicated in patients above 75 years of age, patients with low body weight, body weight less than 60 kgs, and patients with history of stroke or TIA. Definitely you should avoid Prasgrel. But otherwise, young patients, if you choose young patients for Prasgrel, I don't think bleeding is an issue.
And one more thing is, some patients, they'll be coming with.
But most common side effect with ticagrelor I have seen is breathlessness.
That's what I'm
breathlessness
telling
of
about.
unexplained cause. That is a worrying thing.
Post PCI, good LV function
Yes.
They'll be complaining of breathing difficulty,
Yes.
but I'm really
Yes.
scared to stop ticagrelor. I'll just reassure them and I'll continue ticagrelor
Yes.
on those patients also.
Yes.
So usually the breathlessness is self-limited. So what the literature says is, and even in a clinical scenario we have seen, these patients, they complain of breathlessness or sometimes even a missed beat or a ventricular ectopic beat
Yes.
for the first 1 month.
Yes.
So at the end of 1 month, either they get adjusted to this symptom or the symptom just disappears, because in the subsequent follow-ups, majority of them, they don't complain. And this symptom is usually common in patients who have allergic airway disease, smokers, or COPDs.
Yes. Yes.
The normal population, the incidence is very less.
In some patients, actually, there were, a few patients, probably, about 3 to 4 patients in my follow-up, in whom I was forced to shift from ticagrelor to clopidogrel because of this, continuous complaint of breathlessness. Not many, but a few, probably about 3 to 5 patients. I changed them from ticagrelor to clopidogrel, and immediately their breathlessness went off.
But actually, there is no such indication, sir. If I remember,
Yes.
breathlessness is not one of the contraindication or compelling indication to change ticagrelor from.
Yes,
until
that is
unless
true.
the patient is having any.
But I have seen it practically.
Gopal sir, how did you change from you changed from which drug, ticagrelor to what?
Ticagrelor to clopidogrel. I gave loading after 12 hours. I gave loading dose of clopidogrel 600 mg, and I have changed them to clopidogrel.
Okay.
So, but surprisingly, their breathlessness was almost disappeared immediately after changing to clopidogrel. At follow-up, they are very comfortable. But I don't know. We can do that on a regular basis, but not many. About 3 or 4 patients I have done because of their continuous, complaint of breathlessness, and it is embarrassing to us, especially after doing PCI. The patient complains of breathlessness. It is embarrassing for us, especially in OP. They'll be questioning us, why did I undergo this PCI when my symptom has not gone?
And as there is slide, I'm about to ask, like, did you use anytime 60 mg after 1 year? Ticagrelor 60 mg?
Very less.
60 mg?
Ticagrelor. That
Very
is
less.
what Pegasus TIMI 54 says, that only, na? After 1 year,
yes.
60 mg for 3 years, and 3 years
Yeah,
there is
though
some
it is
benefit.
there, but I'm not using it still, because there is immense pressure on us. Actually, after 1 year of dual antiplatelet therapy, especially in OP, there is immense pressure on us to reduce the pill burden. They will be pressurizing us to reduce the number of tablets they take. So if you again continue 2 tablets of ticagrelor with aspirin again, they'll be complaining again and again that I need to take 3 tablets along with a statin. So see 4 tablets again. So
another thing is,
instead of that, you can directly put a combination of clopidogrel, aspirin, and a statin.
Another thing is, after
not
1
only
year.
That, now yes, sir.
Sitaram.
Yeah.
Another thing is, now after 1 year, if you see because antiplatelet we give to prevent the stent thrombosis, because it has the hardly role in a ISRs, because ISRs it be plaque burden because of the statin might take care, or your drug which you are using in the stent. So after 1 year using with this high intense antiplatelet, to prevent, like, if you have any significant, like, complex lesion and the patient is having thrombotic burden, there might be using. But after 1 year, to prevent the stent thrombosis, because after 1 year most of the time we see the ISRs than the stent thrombosis.
Yes.
So
at moreover, it is very difficult to convince the patient to take so many tablets after 1 year.
It's true.
No, actually, that's the point I wanted to bring out, that beyond 1 year, the choice of continuation of dual antiplatelet therapy again depends upon the clinical scenario.
Yes.
For those patients who have undergone a simple PCI, there is no need, with no other risk factors suggesting that there will be a future increased incidence of coronary revascularization required. So there is no need to continue a dual antiplatelets. We can switch over to a single antiplatelet regimen as well. So that's what some of the newer trials have been mentioning now.
Yes. Yes.
However, in patients who have higher risk for developing future coronary artery diseases, there I think continuing the dual antiplatelet therapy can be made on case-by-case basis.
Yes. Yes.
Yeah. So with this, I would like to thank Dr. Bhopal, Dr. Ganeshan, Dr. Sitaram, and Dr. Karthik for a wonderful discussion. Now we shall move on to the next important clinical scenario, which is atrial fibrillation. Sorry, So another common clinical scenario that we come across. This is a case of a 55-year-old female patient who presented to the OPD with a history of palpitations of 2 days duration, lasting for approximately 15 minutes, with similar episodes experienced 3 months back. She is a hypertensive on telmisartan, but not compliant with medications, no history of diabetes. There is no history of coronary vascular disease, cerebrovascular diseases or cardiovascular diseases, and no history of any major surgery. She belongs to an upper middle class family, vegetarian by dietary habits, not on any antiplatelets or anticoagulants. Her reports, CBC, renal and hepatic function tests are all normal. Thyroid function is normal. ECG at rest was normal. 2D echo was unremarkable. Next slide, please. So how do we approach in evaluating this patient? Her clinical examination, everything was normal. However, a 24-hour Holter monitoring that was advised showed that she had a short run of atrial fibrillation, which lasted approximately 10 minutes. Next slide, please. So now comes the question. Given that this patient, a 55-year-old lady, had a short episode of paroxysmal AF or a Holter monitoring with a history of complaints of only palpitation as the symptom and no other symptoms like giddiness, chest pain, or breathlessness. So how do we start evaluating this case, and which anticoagulant to be started in this patient? If at all, how do we decide on what anticoagulant to be started for this patient amongst the given choices of just an antiplatelet versus a vitamin K antagonist versus direct acting oral anticoagulants? And if started, how long to be continued? And do we need to consider the points such as the age of the patient, the cost of treatment, drug to drug or drug food interactions, compliance with drug, regular monitoring, cardiovascular risk, and bleeding versus ischemia? Next slide, please. Is this the last slide? And also, once we started evaluating this patient, so what are the scores that we usually employ in clinical practice to consider the choice of drug for this patient? Previous slide, please. Whether we take into consideration the Chadwas 2 score, Hasbled, and for bleeding risk, what is the score that we choose commonly? Hasbled score, or do we have any other improvised scoring systems? Should we put her on anticoagulant or antiplatelet or do nothing? What are the recent guidelines? And if she is qualifying for an anticoagulant, which anticoagulant should we put her on? So now with these questions, I would like to open the session for discussion. And I would like to see the comments first from Dr. Sitaram garu.
Hello, sir. I'm audible, sir?
Yeah. Hello.
So,
am I audible?
yeah, sir. Yes, yes.
Can we?
Yeah. In this case, it has shown that paroxysmal atrial fibrillation, does she require anticoagulation or not? If at all she requires, which anticoagulate? and how much duration. So any paroxysmal atrial fibrillation requires the anticoagulation, sir. Anticoagulation therapy they require, because, and we usually see with the score up chart was, especially more than one, definitely she requires. One we may not, because that there we need to calculate the has bleed score. So in this case, she is a female and 50 years, and she has hypertension, 55 years. So
Yes,
score
sir.
might be 2, sir, I think. So definitely she required the anticoagulation, because 10 seconds of atrial fibrillation will be sufficient to cause the thrombotic burden for any patient. And when it comes to the which drug is preferable in this patient, is a vegetable, I mean vegetarian, and the young female and upper middle class. Obviously, the Novak will score over the war for the acetram, because financially she don't have any problem, and Novak is non-inferior to the VKS. And third thing comes to the how much duration is required for a paroxysmal atrial fibrillation patient. And in such cases, duration, we may not say that how much duration, but at least 6 months of anticoagulation might require, as of my knowledge, for this particular case. But when it comes to the other case, when you have these cases might be very clear, we can use the Novaks definitely score over the VKS. But sometimes we have problem, we need to use the non-valvular wave. Is it better to give VKS or the Novaks? And recently they came up with the score of same TTR, that is the therapeutic time in range. Problem with VKA is we need to keep monitor every month, and in monitor also we hardly see a one sample. And if you see the time in therapeutic range, most of the patients, they doesn't have the time in therapeutic range. If the same TTR score, if it is more than 2, and if you still use the VKR, such patients, they will not maintain the therapeutic range, and our aim, which was to prevent the embolism, might not be fulfilled. So if the same TTR score is more than 2, you can preferably go for the Novaks, because which is not inferior to the VKS. Anyways, bleeding is the higher bleeding is there, then you can go ahead with the Novaks. But if at all among the Novaks, Apixaban I choose, because it is a lesser bleeding risk when it comes to the any other either GI bleed or the IC bleeds. And then I go for the dabigatran. If the Apixaban, previously Apixaban was not commonly available, and after COVID now we are getting all drugs more or less same price. So either Apixaban or the dabigatran.
Okay. Sir, can we have the previous slide? Yeah. So the question is, Dr. Ganeshan, sir. Sir, are you
audible?
Yeah. Am I audible?
Am I audible?
Yes, yes.
Yes, sir, you're audible.
Sir, the question is now, so we all agree that this patient is a high-risk patient for case for developing future cerebrovascular events, especially the idea of starting an anticoagulation after having detected prevent a possible stroke in the future, given that she is a postmenopausal lady, she has symptoms of atrial fibrillation, she gets symptomatic when she develops palpitation, and the Holter did show that there was a paroxysmal wave. Now the question is, once we start anticoagulant, how long do you think she would qualify to continue? As Dr. Sitaram said, that would require a minimum duration of antiplatelets for 6 months. But what are the clinical evaluations that you would like to continue before you consider stopping them permanently from anticoagulation? Number one. Number two, if you are considering for a lifelong or even a longer duration anticoagulation for that lady, what are your points that you would look for? in considering that anticoagulation. And hello, am I audible?
Yeah, intermediate. I couldn't hear your question because signal is poor here. I half hear your question. I will try to answer that one. This patient, no, Chad was for his 2 was there.
Yes.
Am I audible?
Yes, sir.
So this case, no, only hypertension is there, and we have to took the female sex category only in addition to any the important like hypertension, heart failure, or diabetes, and previous stroke. And independently, we cannot take female sex category as one of the risk factors. So this case, I will consider for this chart was for only one. She is having only hypertensive, only the risk factor is there. She is in common following category of low risk for embolism, and we should not we should not complicate this case with bleeding unnecessarily, giving a high dose of any anticoagulant. So I will think this case is low risk for embolic complications. So I will start with always, unanimously everyone will choose novel oral anticoagulant only. Vitamin K antagonists are highly unpredictable anticoagulation effect was there, and you have to monitor that one. And so many other drug to drug interaction, drug to food interactions will be there. And bleeding also will be more compared to any novel oral anticoagulant. So unanimously, we will start with novel oral anticoagulant in spite of she fall into low risk for embolic complications. And think this atrial fibrillation duration is the second question. Duration, you cannot say that is a particular time. I think you have to continue for lifelong. The paroxysmal AF recurrence chances are very high, and we have to look for any other organic heart disease. Is there LA dilatation, any valve regurgitation or stenosis should be there. If it is there, then I think you have to continue. If patient may develop this kind of problem later also. So in that situation, we have to continue for lifelong. So once you started oral anticoagulant, even paroxysmal AF, I think I will continue even lifelong, at least in low dose. I prefer either rivaroxaban or apixaban or dabigatran. No difference in there is no comparative studies. The 8-to-8 comparison was not there. But the dabigatran we have to give twice daily dose. That is one disadvantage is there. The other drugs that rivaroxaban you can give once daily. So we will start a novel oral anticoagulant, and I will continue mostly lifelong, at least low dose. Hello.
Thank you, sir. Thank you, sir.
Hello.
Yes, sir. Hello. Yes, sir.
Yes.
That's interesting, sir. You brought up one more interesting point in this discussion about whether to consider the female patient as the risk factor category in calculation of stroke risk. This was actually, in fact, yes, sir. Yes, sir. Even in the ESC guidelines, also, I think they have made a mention. Hello, am I audible?
Hello, you can audible, sir. You can proceed.
Yes, sir. Yes, sir. Sir, that was another interesting point that you have brought out on whether and under what circumstances can we consider female sex as the risk factor for stroke. In fact, that is the reason why this case was brought about, showing that there was a postmenopausal lady with an atrial fibrillation. Yes, the ESC guidelines also, they had made a discussion of this based on some of the studies. Under what circumstances can they negate female sex for stroke risk calculation, and what circumstances they need to include it. So if we go by those, this lady being in a postmenopausal state who has higher risk of developing cardiovascular events, including atrial fibrillation, stroke, and other things based on the epidemiological data that we have. So she definitely qualifies for stroke, higher stroke risk category qualification, sir. So And based on that, yes, it's again debatable depending upon individual physician's choice, but certainly she qualifies for an anticoagulation. But the question is, once we start, there is no stepping back. So if we start, how do we get on that? Whether beyond 6 months of duration, what are our choices to stop the anticoagulation permanently, or do we have to compellingly continue that? So how do we monitor? Because that is the most important thing now. So Dr. Bhupal sir, what is your comment on this point? Beyond 6 months, once started on anticoagulation.
No, once for
What do
AF,
you
there
think?
is no set, timeline that once you start the patient on anticoagulation, he or she should continue anticoagulation. Once you have decided that the patient needs anticoagulation, I think he or she should be on anticoagulation lifelong. And especially in such cases of paroxysmal atrial fibrillation, if there is a structurally normal heart, you can consider, radio frequency ablation, AF ablation. That is one option available. So if if uh, if if it is a structurally normal heart, and if you refer him or her for AF ablation to an electrophysiologist, if it is successful, probably you can stop anticoagulation. But otherwise, once you initiate them on anticoagulation, they need to be on anticoagulation lifelong.
Yeah, I do partly agree with that, but you brought about a very interesting point here again. That this patient who had a paroxysmal AF, if subjected to an electrophysiological study and if she undergoes a pulmonary vein isolation, and if a long-term monitoring doesn't show that there was any recurrence of atrial fibrillation, then definitely, yeah, we can downgrade from oral anticoagulation to no anticoagulation beyond 6 months of therapy. But as you said, that if the patient has been frequently visiting the outpatient department and she frequently complains and
your voice is not able to hear your voice.
You are not audible.
this is the problem. Yeah, this signal.
Signal problem.
Yeah. Am I audible now?
Yes,
Yeah,
sir.
yeah.
Yes, sir. So this was another important this thing, sir. Suppose if the patient has paroxysmal AF and she qualifies, as you pointed out, for radiofrequency ablation and pulmonary vein isolation.
Karthik Naid sir, we lost your voice.
Hello.
Hello.
Yeah, Karthik sir, now audible, sir.
Am I audible, sir?
Now audible,
Yes,
sir.
yes.
Yeah. So suppose if this patient shows any recurrence of atrial fibrillation on future monitoring, yeah, that's when we can always consider her for long-term anticoagulation,
Yes.
provided her bleeding risk remains low and the stroke risk always on the subsequent calculation or monitoring shows that she's having a high stroke risk profile. So with this, I would like to, next slide, please. Yeah.
You're
so
not audible.
about the recent ESC guidelines, yeah, I would like to, hello, am I audible?
Yes,
Yes, yes, yes.
Yes. Thank you, sir. So with this, I think we'll move on to the slides, discussion slides, and I would like to introduce some of the recent ESC guidelines and what the guidelines say, and we can further discuss. Yeah, this is about the Chadwa score, as we all know, and we calculate in our day-to-day practice. And this is the Hasbled score which we use, and it has been endorsed by the European Society of Cardiology to use these two scores while considering the patient for anticoagulation therapy, whether it is vitamin K or direct-acting oral anticoagulant. So next slide, please. Next slide. Next slide. Yeah. So stroke prevention in atrial fibrillation. So in the guidelines, it was shown, the previous slide. Yeah. So we have seen that definitely warfarin as against the placebo or a combination of warfarin with other antiplatelets like aspirin or clopidogrel, or comparison of warfarin versus dabigatran. Definitely stroke prevention was good with warfarin as compared to other agents. But then the side effect profile of warfarin, although it was efficacious in reducing the incidence of stroke in patients with atrial fibrillation, however, the other side effect, which was one of the major one and the important one discussed in the clinical society, is the bleeding risk. So the bleeding risk of warfarin was relatively high. So the risk and the benefit ratio with warfarin as compared to its other counterparts like dabigatran or rivaroxaban or apixaban showed that the bleeding risk was relatively high when compared to those newer anticoagulants. However, albeit at the very modest increase in the benefit of offering less stroke benefit. Next slide, please. So when an oral anticoagulant is initiated in a patient with AF who is eligible for a newer oral anticoagulant, and NOAC is recommended as a preference to vitamin K antagonist. So what was a class 2 indication in the previous guidelines has now become a class 1A indication. So such is the evidence that is available now with the usage of direct acting oral anticoagulants, and it now competes well with VK, vitamin K antagonists in taking a class for a class as an anticoagulant for stroke prevention in patients with atrial fibrillation. Next slide, please. Sorry. Next slide. So we all know that vitamin K therapy has certain pharmacokinetic and pharmacodynamic limitations. That it allows us for a very narrow therapeutic range with where we have to keep the INR between 2 to 3, and we have to closely monitor this patient, which is again a very cumbersome process. And on a long run, studies have shown that it is more expensive than continuing just the the newer anticoagulants, which do not require such close monitoring. It has a lot of food and drug interactions. It has genetic variations, and it has a slow onset offset of action. So whenever there is an incidence of bleeding, it becomes very difficult to reverse that bleeding incident. And such is the problem with even the newer anticoagulants, because we don't have, other than dabigatran for rivaroxaban or apixaban, we don't have any antidote. However, the incidence of major bleedings have been less as compared to that of vitamin K antagonists. Next slide, please. Next slide. Yeah. So this is again one of the common slides that are usually discussed in the scientific meets on comparison of dabigatran, rivaroxaban, and apixaban. But I would like to make a point here that none of these were a direct head-on comparison with each drug. So they were the drugs which were compared with the placebo and also with vitamin K antagonists to see their efficacy, and comparing their efficacy and superiority with vitamin K antagonists. They were never a head-on trial. So this slide only points out the individual benefits of the drug from each trial. Like the relay trial showed that the incidence of stroke was less, as less as that of vitamin K antagonists. However, the incidence of major stroke. Next, can we have that next slide, please? Yeah. So if we see the risk of major bleeding, So when compared to their placebo counterparts or the vitamin K antagonists, both dabigatran at 110 mg and 150 mg showed to be superior to vitamin K antagonists, and they were non-inferior to the vitamin K antagonists in terms of prevention of primary endpoint, that is the stroke. Similarly was the observation seen with rivaroxaban and apixaban at the dose of 20 mg and 5 mg respectively. So, however, we don't have any direct comparison trials to compare the efficacy of these three anticoagulants amongst themselves to show the superiority of one over the other. Next slide, please. So in the RELY trial, which involves dabigatran at a lower dose of 110 mg and dabigatran at a dose of 150 mg BD, the lesser dose, although had a reduced incidence of major bleeding as compared to the 150 mg, the higher dose. However, the incidence of ischemic stroke was significantly higher with the low dose subset of population, that is the population receiving 110 mg when compared to the population receiving 150 mg. So when the risk benefit analysis was done, the stroke prevention at 150 mg was better as compared to 110 mg. However, with only a slight increase in the incidence of major bleeding. Next slide, please. When it comes to the side effects of dabigatran, the risk of GI bleed was seen only with the 150 mg subgroup, but the incidence was very low with the subset of population which was receiving 110 mg. The similar findings were noted even with rivaroxaban in the Rocket AF trial, when rivaroxaban given a 20 mg dose had higher incidence of GI bleed when compared to the control population. So if we come across, next slide, please. Do we have a next slide?
Sir, slides are over actually.
Okay. Thank you.
Now we
So,
can have this question and answers.
observations, I would like to make certain few additions with respect to dabigatran. That whenever we come across elderly patients or the patients who have a higher bleeding risk based on Hasbled scoring, but they are the patients who are tough to be monitored on vitamin K antagonists, requiring difficult finding it to be very tough to monitor them on a regular basis. I think in those scenarios, 110 mg of dabigatran can also be considered as an alternative to 150 mg. But based on the indirect study comparison, especially in elderly patients, those who are above 75 years of age, the preferred choice by default in majority of these populations becomes the apixaban, because apixaban has shown the lowest incidence of bleeding in this subset of populations, and that is why in elderly people, usually they choose apixaban. But if we come back to our original case, the lady who is 55-year-old, she qualifies for the choice of anticoagulant. However, now based on the cost consideration, patient consideration choices, if she is agreeing for a direct acting oral anticoagulant, she is fit. She is a person who can be started on any of the three anticoagulants. But since the stroke risk is low, so hitting her hard with a high potent anticoagulant would be a risky option, as pointed out by Dr. Ganeshan sir. So choosing her at a dose which is optimal to just prevent the stroke by at the same time reducing the incidence of bleed would be a right thing to do for that lady. So based on these findings, I would like to see. I would like to ask Dr. Karthik, sir, what would be your choice among the three anticoagulants, that is dabigatran 110 or 150 versus rivaroxaban 10 or 20 versus apixaban for this lady?
Yeah, this lady, if for stroke prevention, definitely I would have used dabigatran, because dabigatran is the first Novak with it has a huge evidence also, based on trials wise also, and if what take to once daily dosing, the rivaroxaban is good for once daily dosing, either a dabigatran or a rivaroxaban. And considering this patient is having a CHA2DS of 2, so it's a class 2-year recommendation to start her on an oral anticoagulation, preferably NOAC, and lifelong, obviously. But thing was, as Bhopal sir told, definitely we can consider in these patients for AF ablation. We can take for AF ablation, and after that we can monitor them either with a loop recorder or a extended Holter, and we can see how are their events. But then we can consider of stopping anticoagulation if the patient is really successfully ablated with no events. But otherwise, we cannot predict the paroxysmal AF when it will come. So definitely it's a lifelong treatment for these patients.
Yes. Yeah, I do agree, because in a country like India, where the patients are most likely to be non-compliant than compliant, so it is always better to assume the worst for the patient and do the best. So
best
whenever
thing
we come
about,
across patients whom we can suspect. Sorry?
Nothing, sir. Carry on. Yeah.
Yes, sir.
The best thing among NOACs
Hello?
is that no monitoring is needed for NOAC. That is very
Exactly.
it's really a boom or something, like a gift that has given for these patients, because doing every week INR, monitoring INR, if the INR value is less than 2, again running to doctor, adjusting the warfarin or acetron dose, again it will cross more than 3. Sometimes they come with bleeding. So many problems with this INR monitoring.
Also,
and
there is
every
lab to lab variation on INR.
yeah, lab to lab
It is
variation.
not standardized.
It's very difficult. The Novak
same sample in 2 labs, they give 2 different values.
Yes.
You don't know which to rely.
So the inventing the Novak is something really like a gift for the patient, that they need not monitor the INR and all, and comfortably many patients, they don't come with any kind of bleeding. Very maybe rarely they come with some bleeding, but definitely they won't come with any bleeding, and we can comfortably give either dabigatran 110 BD or apixaban 5 BD. Even for these COVID patients also, I prescribed. Many people are. The problem is many people, they are scared of giving these drugs, like, because they won't be using this. Even I saw many pulmonologists or physicians also prescribing apixaban 2.5 OD or 2.5 BD. They are considering as high dose, like that. So even my parents got COVID, and even I got COVID, and I used apixaban 5 BD also. Even for myself, I used apixaban 5 BD for 1 week. So there is no issue of much bleeding risk with any of these patients, and comfortably we can give like 110. I never used 150 BD of dabigatran, but 75 BD I never used. Usually I use 110 BD only.
Why you have used Karthik? Why you have used apixaban than the dabigatran?
Apixaban for myself.
Why you have
just nothing specific. I have used apixaban, that's all.
Because dabigatran, the patients, especially dyspepsia and GI bleeds, if you see, comparatively far, I mean, they have more number of cases.
It
because
means
the
side
renewal
effects,
PCI,
people are reporting the side effect.
It is there, the dyspepsia and GI bleeds.
Okay.
That is the one thing where the apixaban.
Apixaban is safest of all.
Yes. So probably that is the one scoring event other than the renal failure. Like it is the up to 30 EGFR you can use, I think, apixaban.
Sir, with rivaroxaban, what are the side effects?
For less than 30, it has been approved. Apixaban recently.
What's the what? I didn't. What? Can you repeat?
Renal failure.
Renal failure. Previously, apixaban. It was. I mean, there was a. I mean, caveat for patients with less than 30 GFR less than 30. Recently, it
Okay.
got approval for usage in patients with GFR less than 30 as well.
Oh. And
So,
what about rivaroxaban, sir? What are the side effects people reported to you? Patients reported with rivaroxaban.
rivaroxaban is also quite safe, and compliance is better with rivaroxaban because single dose, and it needs to be taken with food. I don't know the reason why, but the prescription, I mean itself.
Yeah. I think for absorption, maybe some better absorption. I think.
Maybe it is lipophilic or something. I don't know the reason exactly, but it needs to be taken with food.
It needs to be taken with food. Yeah, that we should not forget. Yes.
And compliance is better with rivaroxaban, and nowadays, I mean, the patent has also is completed. So cheaper variants of rivaroxaban are available. So rivaroxaban, you can consider rivaroxaban as well because single dosage, easy to administer.
Okay.
I do agree. Actually. In the COVID era, especially when the parenteral anticoagulations are running out of stock, so we always have to look at some alternative to start with. And at the same time, I'm sorry, am I audible?
Sir?
Yeah, yes.
Am I audible?
Sorry. Yes, sir.
Yeah.
Yes, sir.
So at the same time, since we know that in the COVID era, it's a prothrombotic state, and we see that D dimers are sometimes suddenly jumping and going over the skies. And especially at the time when you don't get the anticoagulants, parenteral anticoagulants on time, or there is lack of stock. So using the direct acting oral anticoagulant at the right dose becomes one of the important considerations now. So readily, these were the three main contenders for the choices, but then choosing the patients also, as has always been the case scenario, choosing the patients also becomes very important, especially in our institute when we see that the patient, the first by default, the first oral anticoagulant that we have been using is rivaroxaban. But since majority of the patients were middle-aged and elderly with a lot of other comorbidities and having high HAS-blood score, so we had to somehow control the bleeding risk by modulating the dosage of these anticoagulants. So instead of giving at the prescribed international dose of 20 mg a day, we have to just Indianize the dosage, as we say, because our patients are having lower BMI and higher bleeding risk, and compared to that of the Western population, where the studies were carried out. So elderly patients, we have kept the protocol of using apixaban as the anticoagulant of choice because we want to control the bleeding risk completely. And we have seen so far that we have not touched wood, but we have not come across out of the 1,000 patients that we have treated, we have not come across any major adverse bleeding events so far, or we have not even come across moderate bleeding episodes. There has been 1 or 2 episodes of minor gum bleeding, which probably might be attributed to the mechanical trauma induced by the patient. Other than that, we have not come across any adverse events of bleeding associated with the usage of these two anticoagulants. And luckily, since we were able to follow up these patients, we saw that on day 2, day 3, their D dimers were also coming down. They were slowly decreasing with the usage of these oral anticoagulants. However, in a couple of scenarios where we came across about 7 patients where the D dimer was not coming down as expected, even after starting these anticoagulations at the end of 3rd, 4th, or 5th day, we decided to switch them to parenteral heparin, conventional heparin, since Clexane also was not available, the low molecular weight heparin. So we switched over to conventional heparin, and we used it at the standard prescribed dose. And we were quite surprised to see that after 48 hours, the levels of D dimer was drastically coming down. In fact, the observation that we have seen, in fact, even now they have shifted one patient to the ICU, which we were discussing, who was complaining of chest pain for the last 24 hours. And the ECG was showing only subtle changes. So many a times in this COVID wards, we have seen the first call that comes for is for the patient with chest pain. So we many a times the debate is the chest pain is cardiac in origin, but no, the chest pain is less likely to be cardiac in origin in these patients and more likely to be pulmonary vascular cause in origin. And probably the patient is having a pulmonary thrombotic event, a pulmonary thromboembolism. So I could, luckily, because there was a good backup of residents and the laboratory support, and we had the data, we could see that the D-dimer levels, which were normal before, suddenly jumped over the roof for these patients, reaching up to 2000. In fact, just now I received a message of a patient with 2900 D-dimer who was having just 500, 600 D-dimer at the beginning of admission. So this is one thing which we have observed could be one of the reasons for these patients developing bradyarrest. So again, there was an interesting discussion with the anesthetist today, where we were having a discussion why the patient who was all right at 1 a.m. suddenly dies at 2 a.m. So luckily, because these patients were in the ICU and everybody was watching and monitoring them, the first question I asked was it a VT or a brady? The patient said, then the debate came saying that it was a brady. So how many more patients did you notice having brady before the arrest, before the final event? So then came the discussion that yes, majority of these patients might be developing pulmonary embolism. And although sinus tachycardia is very common in patients who have pulmonary embolism as one of the most common clinical signs, but when there is a sudden massive pulmonary embolism, the patients can go into sudden brady and arrest because of hypoxia. So although the patient had a normal oxygen levels at the initial moment, but after the incident event, the sudden intense hypoxia might have driven the patient towards brady and arrest. So this was again a very interesting discussion that we have today.
Sir, these patients are on which anticoagulant? What you told just now?
No, sir. Some of these patients were on low molecular weight heparin, some were on conventional heparin. But I feel that these patients were not adequately anticoagulated, because I think we'll have to do an audit for all these patients to see how.
Actually, I feel like in those patients in whom there is a sudden jump of D-dimer like this, we should straight away go with our 5000 QID of unfractionated heparin without second thought, because that is the one thing which we can definitely prevent in that ICU patients, and it won't cause much bleeding also. 5000 QID we are very commonly using. So and even if there is a small pulmonary embolism also, definitely that will help. So for few patients I switched like that immediately whenever there is a D-dimer rise suddenly, switch it to 5000 QID, and they are comfortable and got discharged also.
No, that is true. I totally agree, because that is what we are doing now. In fact, we are hitting hard with higher dose of anticoagulants without any hesitation, because what I saw initially.
No, sometimes I doubt D-dimer. Does it truly represent the procoagulant status of the patient or not? Because many times patients with severe sepsis and all, they have highly elevated D-dimer levels. Though maybe sometimes I feel that way, but I don't know. I have a doubt sometimes. Does elevation in D-dimer?
I would not completely agree.
Sorry, your voice.
I would not.
Sorry.
Am I clear now?
Yes.
Yes. Sir, that's again a very interesting question, because even I used to think initially whether D-dimer.
No, again it's gone, your voice.
See, D-dimer is also an inflammatory marker. So
Hello, I'm sorry.
Hello, yes, now you are audible.
Sorry, the signal problem. Okay, sir. No, actually, I do agree that initially when I was analyzing the patients, I was thinking why people are going so crazy with anticoagulation, D-dimer, and all those things. Because D-dimer can be just like any other acute phase reactant protein, which might be elevated in any inflammatory state.
Yes.
But then luckily I had I had a control population on the outside of non-COVID zone who presented with severe respiratory illnesses of non-COVID origin, where out of my curiosity, I started checking the D-dimer levels just to see whether D-dimer were elevated in this subset of populations too. But to my surprise, I saw that there was no elevation of D-dimer in those non-COVID respiratory illnesses patients.
Okay.
So that was one of the first observation I could see. And the other analogy that I was discussing with the anesthetist is whenever we intubate the patient, we have seen that several times. If there is even slightest delay in intubation of the patient first develops a brady on the monitor. You would have seen the heart rate gradually drops. So it is the hypoxia that is driving the patients, and in an already damaged lung, any embolic event would cause such an intense hypoxia that these patients who are already on 15 liters, 10 liters of oxygen, any thromboembolic event in the lungs, it might just shut down the whole lung, and the patient may develop severe hypoxia and brady. So these were the things that I observed, and that is why the reason why we were discussing this is we were just trying to contemplate whether these patients should be done an alternate day or every third day evaluation for inflammatory markers, including D-dimer, which is quite an expensive effort to do, given that today cost constraint has become very.
And one more thing, why I stressed so much about this anticoagulation, because I have my friends who are vascular surgeons and pulmonologists. They'll be discussing and they'll be sending the cases of popliteal artery thrombosis in the recovery phase of COVID, and with the pulmonary, even like peripheral thrombosis. So these are all, once if the patient is having such kind of arterial thrombosis, it's very difficult to manage, and we can't even take for surgery also. We cannot stop anticoagulation also. It becomes very difficult. So it's better to go in the initial phase itself with full dose anticoagulation, especially if the D-dimers are at higher levels.
Yeah.
I think our discussion shifted from usual discussion to COVID.
Yes.
Today it's all COVID. That's what has happened now. In fact, there was an interesting case of a patient who developed new onset AF while he was in COVID ward on his sixth day of illness. So this was another interesting case scenario, but luckily his D-dimers were borderline elevated and he was already on anticoagulation. So nothing happened to him, and we were able to discharge him. To my surprise, I saw that the AF was there for about 48 hours and then it spontaneously resolved. But however, I decided that since I thought I would consider this as a new onset AF, and I put him on a rhythm control strategy with Cardrol, 100 mg BD, and he has maintained the rhythm well, reverted to sinus. So probably he might come down for a follow-up after 10 days. I have to see what's happening with him.
In COVID, except for steroids and anticoagulation, I don't think any other drug has any role.
No. Actually, this pure monoclonal antibody,
newer one, okay.
Again, this was debatable. The newer monoclonal antibody, that is basilizumab, when given in the mild or moderate phase of the illness, has shown that it reduces the duration of illness.
No,
but as you rightly pointed out,
they are saying the same way initially. After 3 months,
correct.
WHO comes up and says it has no role. We will be made fools in front of public. That is what is happening.
No, everything is like that only, sir. From last 1 year,
initially, what they said, plasma is, helpful. Remdesivir is helpful. What they have launched, they have sold lakhs of crores of, vials of remdesivir. Now, all of a sudden, WHO comes up and says remdesivir has no role, and entire medical fraternity is made, fools in front of public.
No.
Yeah, even Baba Ramdev also said that only in one interview. What he told is actually partially correct.
No. But actually, no, I don't know how to debate that. But I have treated about 25 to 30 people on a home quarantine basis. So what I was following is that on the third day of their illness, I tell them to do a complete blood work. just to see what is the level of the inflammatory markers. Until then, I don't start them on any medications other than just paracetamol. And on the third day, when I see that the inflammatory markers are going high, that is when and clinically, if they are still symptomatic, showing certain danger signs of symptoms like high-grade fever, myalgia, diarrhea, persistent, or complaining of breathlessness or saturation going to 95. So third day is the cutoff when I start them on steroids.
Okay.
And touch wood, by God's grace, all those people with oral steroids itself, they have done well. And that too, just a simple tablet of dexamethasone. And I never forget to put them on a small dose of anticoagulation.
Yes.
Yeah, so I never forget to put them, and I have started them on anticoagulation also, suggesting that it would help them. But now I have seen. Then the next 2 days is the follow-up phase, and if I see that there is any slight decrease in the saturation levels, that's when I ask them to get an X-ray done to decide on to start any other treatment. I mean, not X-ray, sorry, CT. Otherwise, I just repeat the markers on the 7th day, 3rd day, 7th day. So that is the cutoff. Because in this pandemic, we have seen whatever is happening, it's happening between the 3rd and 7th day.
Yes.
Yeah. So then another interesting point, sir. What is the role of statins in this pandemic?
Statins, if the patient is on
Are we all
statins,
considering usage of high-dose statins because of its pleiotropic anti-inflammatory effects?
no, if the patient is on statins, I continue them. If he's not on statins, I don't start them on statins for the purpose of COVID. So if he is already on statins, I continue them. That's all.
Okay. How about others? Ganeshan sir, how about you?
Fortunately or unfortunately, I don't know. I am not involved in COVID patient treatment care. We are involved only in cardiac
actually, recently
care
there
only.
was
So I just simply hearing your discussions. So I learned something from you.
Yes, sir. Sir, there was a recent Irish study on the role of statins, especially statin with fenofibrate. They showed that there is some pleiotropic beneficial effects of statins in this inflammatory phase of the viral fever, viral infection. And they are suggesting that statins at a moderate dose can still be used. Although it has not shown to have any mortality benefit, but it has helped the patients, those who are recovering, they were recovering faster than the control population. The duration of illness has been reduced. So this was one of the study that had come across.
No, they have tried every drug available on earth for COVID, right? From HCQ, zinc, I mean, what not. So.
No, the thing is now they are giving excessive zinc only precipitated mucormycosis.
Precipitated mucormycosis. See, basically, there is no complete evidence for any drug. So everyone is trying every drug. So probably only steroids and anticoagulation, I think, are the cornerstone of therapy for COVID patients.
Yeah, that's all, sir. That's all.
Everything else is only on a trial, this thing. So we don't know which works for whom, and we don't know whether it was the reason of, I mean, it was a drug that has, that has helped him recover, or it was his fate. We don't know. Ultimately, patients with CT score 25 by 25, some patients they have recovered very well on home quarantine. Patients with 10 and less than 10, they have deteriorated and they have lost lives. So it is very unpredictable. I don't know. I mean, if our treatment is helping or not. I come to that phase of understanding for COVID.
Okay.
Yeah.
Okay, sir.
I think we are late.
Okay,
shall we conclude the session, sir?
Yes.
Yeah.
We'll conclude. So thank you very much. It was really nice interaction.
Yeah.
So we take this opportunity to thank Dr. K.C. Karthik Naidu sir for moderating the panel discussion. and ensuring the audience are engaged with clinical relevant experience. And we also thank Dr. V.S.R. Bhupal, Dr. V. Sitaram, Dr. V. Viswanath Karthik, T. Viswanath Karthik, Dr. R. Ganesan for sharing their clinical experience. We would also like to thank all the doctors who have joined us for this panel discussion. We at Alchem Laboratories will continue to serve doctors and patients by making our products available, especially TSAT, Demiclot, and Ticavic. Thank you, doctor.
Thank you.
Really, it was a nice interaction.
Yeah, thank you.
Thank you.
Thank you, sir. Good night, sir.
Good night.
Thank you. Good night.
Yeah. Good night.
Good night.
Bye.